Hello and welcome. Today we'll be discussing a complex urinary system condition, the ureteral fistula. We'll explore what it is, how it develops, its symptoms, diagnosis, treatment, and more. So, let's dive in and understand this intricate medical issue. The etiology or causes of ureteral fistulas are varied. The most common culprit is iatrogenic injury, meaning the fistula develops as a result of a medical intervention. This can happen during surgeries such as hysterectomies, bowel resections, or other procedures in the pelvic region. Trauma, both blunt and penetrating, is another significant cause. Furthermore, radiation therapy to the pelvis, often used to treat cancers, can damage the ureter and lead to fistula formation. Infections, particularly those involving the urinary tract or surrounding tissues, and inflammatory bowel diseases like Crohn's disease, can also contribute to the development of ureteral fistulas. Finally, in rare cases, ureteral obstruction, tumors, or congenital abnormalities can lead to this condition. Let's delve into the pathophysiology, or how a ureteral fistula develops. A fistula, by definition, is an abnormal connection between two epithelialized surfaces. In the case of a ureteral fistula, this connection forms between the ureter and another organ or the skin. When the ureter is damaged, whether by surgery, trauma, radiation, or infection, the normal healing process can be disrupted. Instead of the ureteral tissue repairing itself, an abnormal channel may form, allowing urine to leak from the ureter to an adjacent structure. This leakage can lead to inflammation, infection, and a variety of other complications, depending on the location and size of the fistula. The constant irritation caused by urine leakage further impedes healing and perpetuates the problem. The exact epidemiology of ureteral fistulas is difficult to pinpoint, as many cases may go undiagnosed or unreported. However, we do know that the incidence is higher in patients who have undergone pelvic surgeries, particularly radical hysterectomies for gynecologic cancers. Similarly, individuals who have received radiation therapy to the pelvis are at increased risk. Women are statistically more prone to developing ureterovaginal fistulas due to their anatomical proximity, with the ureter being close to the vagina and uterus. While relatively uncommon, the overall occurrence of ureteral fistulas underscores the importance of careful surgical technique and vigilant post-operative monitoring. The signs and symptoms of a ureteral fistula can vary significantly depending on the location and size of the fistula, as well as the organs involved. The most common symptom is persistent leakage of urine, often from the vagina in cases of ureterovaginal fistulas. This can lead to skin irritation, excoriation, and a characteristic urine odor. Patients may also experience abdominal or flank pain, fever, recurrent urinary tract infections, and hematuria or blood in the urine. If the fistula involves the bowel, patients may have fecaluria, meaning stool in the urine, or pneumaturia, meaning air in the urine. In some cases, the fistula may be asymptomatic, especially if it's small, but these cases can still lead to complications like kidney damage if left untreated. Diagnosing a ureteral fistula typically involves a combination of clinical evaluation and imaging studies. The physician will begin with a thorough medical history and physical examination. Imaging modalities like cystoscopy, where a camera is used to visualize the bladder, and uroscopy, which visualizes the ureter, may be performed to identify the fistula opening. A retrograde pyelogram, where contrast dye is injected into the ureter through the bladder, can help define the anatomy of the fistula. A CT urogram, a CT scan with intravenous contrast, is also commonly used to visualize the entire urinary tract and identify any abnormalities. A vaginal dye test, where dye is inserted into the bladder, can help confirm the presence of a ureterovaginal fistula if leakage of dye is observed in the vagina. Sometimes, MRI may be utilized for better visualization of soft tissues. Ureteral fistulas can be classified based on their location and the organs involved. Some common types include ureterovaginal fistulas, which are connections between the ureter and the vagina, ureteroenteric fistulas, connecting the ureter and the bowel, ureterocutaneous fistulas, where the ureter opens onto the skin, and uretero-uterine fistulas, connecting the ureter and the uterus. The classification is crucial for determining the most appropriate treatment strategy, as the approach will vary depending on the organs involved and the complexity of the fistula. Treatment and management of ureteral fistulas depend on the size, location, and complexity of the fistula, as well as the patient's overall health. Small asymptomatic fistulas may resolve spontaneously with conservative management, which includes bladder drainage via a catheter to allow the ureter to heal. Larger or symptomatic fistulas typically require surgical intervention. Surgical options include open surgery, laparoscopic surgery, and robotic-assisted surgery. The specific surgical approach depends on the type of fistula and the surgeon's expertise. The goal of surgery is to close the fistula and restore the normal anatomy of the urinary tract. This may involve resecting the damaged ureteral segment and re-implanting the ureter into the bladder, a procedure known as ureteral reimplantation. In some cases, a stent may be placed in the ureter to promote healing and prevent stricture formation. Minimally invasive techniques are increasingly preferred due to their smaller incisions, reduced pain, and faster recovery times. Preventing ureteral fistulas involves meticulous surgical technique during pelvic surgeries, especially those involving the uterus, bowel, or major blood vessels. Surgeons should have a thorough understanding of the pelvic anatomy and take precautions to avoid injury to the ureters. During radiation therapy, careful planning and shielding of the ureters can minimize the risk of damage. Prompt diagnosis and treatment of urinary tract infections and inflammatory bowel diseases can also help prevent the formation of fistulas. Post-operative monitoring is crucial to detect any signs of ureteral injury early on, allowing for timely intervention and prevention of fistula development. The prognosis for ureteral fistulas is generally good with appropriate treatment. Surgical repair is often successful in closing the fistula and restoring normal urinary function. However, complications can occur, including ureteral stricture, recurrent fistula formation, and urinary tract infections. Long-term follow-up is necessary to monitor for any recurrence or complications. Recent research has focused on developing minimally invasive surgical techniques and improved materials for fistula closure. These advances aim to reduce surgical morbidity and improve patient outcomes. Furthermore, studies are exploring the use of regenerative medicine approaches to promote ureteral healing and prevent fistula formation after injury.